Really almost should have class today. I wish. We'll vote on who won the elections. I thought it would still be going on. So you don't know, so y'all just voted.
We don't know our grades. We don't know who won.
Well, you know, the lab stuff hasn't been graded yet. In fact, they'll be grading it right now, so that's what they're doing. So we'll let everything go out. I've already looked at the exam. You don't want to know what you made. I'm just joking with you. It'll all come out at one time. As soon as we finish up and I go back upstairs, I'm pretty sure that all the grades will be ready. Then we'll get them loaded and we'll get them out. So before we get 4, probably you'll know what you got.
Do you know what the lecture class average is?
We don't report averages. We don't give those comparative scores, but I think everybody did pretty good. For the most part, it's a pretty good showing. And I think most people knew that walking out the door that it wasn't that bad. So that's about as far as I go. I wish I could be more detailed.
Did you say the question about you?
Me?
Yes.
Yes, Sam, wasn't it?
Well, it's better than what he said in class.
Did you get it right?
In class, he said that you got shot in a goop.
So there's some truth in what you hear, then there's some made up. A little bit of both. I'd say it's partially fake news. Okay, are y'all about brain dead? I mean, seriously, because I want to do a little bit of editing here to kind of get us to a better place and hopefully get you out of here a little bit sooner. This is kind of a good point to kind of draw a line in the sand and say you survived the first phase. And there really is nothing else quite like this, like that moving forward. So it begins to be a lot more integrative. But you kind of have to get all that anatomy out of the way. Do y'all feel like you learned anything?
Yeah.
Okay.
I can't remember.
You've learned so much stuff that you'll come up here in 3 months and go, I know I knew that one time. It's that much content that goes with it. But you have to have that content just to begin framing the picture. You got to start with the body upside down, and then it'll begin to be presented in a lot of different ways with a lot of interventions. It'll be interesting for you. You cannot do physical assessment unless you have anatomy upside down. You cannot get into creating differential diagnoses based on findings if you don't understand what and what can go wrong with things. And you'll be adding more. Physiology will become more predominant in all the modules as we move forward, particularly up through like May, because you've got to cover all your big organ systems. So once you've gotten cardiovascular, respiratory, and renal down, those are 3 of the biggest. Then there'll be a lot of other systems that we're going to work with, but those are huge. If you don't have those, you can't live, basically, very quickly. So I just want to look at you a little bit about where we're going to kind of just recreate the roadmap, because we kind of started and it's just been so much one thing that it's kind of easy to lose track of where you're going. So let me just pick up and look at this with y'all real fast and just kind of tell you where you're headed. Did Professor Brooks talk to you very much about what she was going to be doing coming up? Did y'all cover any of that?
No.
Let me kind of run through this. This week is actually kind of foundational for several different disciplines that you're just going to have to know. And then next week really kind of introduces another phase. So this week's themes really are pharmacology, pharmacotherapy. How do you, what do drugs do? What are they? I know that sounds kind of remedial, but the truth is you really don't know what they are and all of how they are considered and all of the aspects that go underneath that. So this week kind of introduces a lot of vocabulary and a lot of principles and just some big words that will keep coming back over and over again about pharmacology. There's an introduction to laboratory medicine because that's a big piece that will be kind of operating, all throughout the rest of the year. So you'll begin thinking about it, looking at some of the basic labs, and then you will be getting more and more focused labs as you get into different organ systems where those are important to look at. So this week is definitely an introduction for that. There will be, we're going to introduce you to a couple of broad areas of medication, only because they are so pervasive that they really don't fit the normal way that we would teach them. And those two groups are pain medications and anti-infectives. You will start a module, the head, eyes, ears, nose, and throat, in a couple of weeks. And there will be a discussion about pain medications and antibiotics off the get-go. And it will just not be possible to really get into all the details so that it makes sense. It'll just be a bunch of words slung at you, what is this? So the first year this curriculum was taught, there really was not a lot of good orientation to some of these sciences. So last year we put in a lot of stuff to kind of give you a background so that when it starts coming at you, it makes sense. The students from last year were pretty satisfied with that approach, and they felt like they knew where we were going and that there just weren't a bunch of words to memorize that don't make sense. So pain medications and antibiotics, they're huge, they are common, they are hard to get straightened out sometimes, they change, so whatever we teach you is going to change, it's going to change a lot, but this is just going to be the entry in, we'll kind of start there, and a lot of it will hold together. But it will be a challenging area for you to practice just all the time. It is for all practitioners. And if you read the newspaper at all, you know that pain management is a huge thing in Oklahoma across the nation. It's not just opiates, it's all kinds of pain medications, and there are a wide variety of them. They are good for the things they're supposed to do, but they create all kinds of problems when you don't know what else they do. And that's true for medications. Medications are good if they are used properly and in the right ways, in the right doses, for the right length of time, but they aren't candy either. It's very easy for practitioners to get into the habit of using what they want to use to solve the problem that they've got without remembering all the things that happen that are expected, that are not anticipated, and that are sometimes just kind of way off in the weeds, but you can actually be causing harm. And it will happen to you no matter how good you try to be. You're going to end up causing harm by something you do. It's just a matter of how much harm and how aware are you and how do you monitor and those types of things. So we'll look at antibiotics and pain medications. Then you'll get into beginning of prescription writing. How do you do that? There's really a lot of information about it and how to think about doing it. And it's not the same thing all the time, and there's lots of nuances and variations about it. So we really want y'all, when y'all get to the end, to be very good at knowing how to do that. There are a lot of programs that don't teach it all, it just kind of happens, it's just happenstance on rotations, and some of what you learn is actually not right at all, bad. There's a lot of bad prescribing in Oklahoma. I'm just going to be straight down the road here. There's a lot of people using medicines that do not use them correctly. And you're going to be copying people, you're going to copy wrong, and you're just going to get in trouble because everybody's not on top of their game all the time. Or they don't learn, or they don't advance in their understanding. So there's a lot going on, and you'll see that even in writing prescriptions. So we'll look at how to do that, and you get lots of practice. Honestly, when you get out, people will be really impressed with how well you can do that. It's not a common feature in all PA programs, so I think you'll be good with that. Another thing that will happen this week is the first time you will get introduced to the medical humanities. I know y'all have read the book, and some of you may be working on a paper, or maybe not. Maybe not, in the past several weeks, but we'll be introducing that, and you'll get your first glimpse of it and first taste of how to think about being a practitioner beyond just knowing what to do, knowing how to do, and how to be aware of a lot of things that deal with people, humanity. Who are they as people? Things you'd be interested in if they were taking care of you. So that's going to happen, and that's actually a pretty interesting first discussion that we'll have with that. And then next week, we'll have another discussion about that book you've read. So the first one's kind of easy. You don't have to do any preparations. Come and watch the movie, and then we're going to talk about it. And the next week, you do have to have done some stuff before you get there. and you've heard that. I'm also going to preview for you all that there may be some changes in how the medical humanities writing is done. It's been a big issue. We've heard stuff, I've heard stuff for a year. And, you know, right now the thesis-driven essay is kind of the standard that was used last year. We may move that to a writing prompt and kind of change how we do it, okay? I think it actually might be moving in the right direction to go that way. So I'm just telling you, what you do this first go around, do it with all the energy and attention you can do it, but we very well may change it to make it a little more liberating in terms of how much do you have to work yourself up to do a paper. Some people who write papers, it's like pulling teeth, it's painful, it's not natural. And some people very naturally write very well. We don't want this to be English composition class. What we want it to be is engagement with issues that are sticky, okay? And there's a lot of ways to get you to think about it beyond what we talk about in our groups. So I'm just giving you a heads up. Do it the way it's been taught up to this point, but we had a big meeting about it in the past week or two about some modifications that I think are to advantage so that you will get what we want without making it something that we don't want it to be, okay? So that's encouraging. That's really positive. So I'm happy for you, and I think it's going to work out right. At the end of this week, after we've covered all these basic sciences and started getting foundations there, you're going to begin the process of how to interview and talk to patients. It's kind of nice because you've been working with a body that didn't talk back, and now you get to interact with bodies that most certainly do talk back, and most of your patients are going to be talking back to you in one way or another. So Dr. Madad is going to introduce the whole thing about interviewing patients and what we look for and how to actually observe them and talk to them. And it's actually pretty fun, I think. And then we'll move further down. I will talk to you about patient-centered care later in the afternoon. And it's actually really important to talk about it. I'm not going to give away everything we're going to do, but it's very easy at your stage. And it will be very easy when you first get into practice to be more worried about you than the patient. Because you're so worried about making a mistake, and there's things you have to think about, and it just very naturally comes back on home base. And when you're doing that, it's easy to not pay attention to the patient. It's just the way it goes. And then as you get more and more comfortable, you can certainly focus on patients more. So we're going to talk about that patient-centered part, what that means, how does it look. There's some interesting video clips I've got to bring in here that a picture's worth 1,000 words. I just want you to be aware of it. I'm not so interested in testing it all over the place as I am you being aware. So we'll do that, and then all of next week is devoted to learning how to gather information from patients, all about the history gathering. Some of you are scribes, so you know what the parts are, but we'll go through those in details about why you do what you do when you do, how to document things, how to work with an electronic medical record as an introduction, and we're going to introduce you to the medical record that we use over at Good Shepherd Clinic for your first year experience. It's as good as any. I mean, if you've seen one EMR, you've seen one EMR. But they're all variations on a theme, some better than others. So we'll look at that one, and then you will begin learning how to take vital signs, and you will learn how to get history and do vital signs on standardized patients. And we'll just kind of work our way through documentation of information. And on Friday, a week from this Friday, you'll actually have a situation where you go in with the patient, gather information, do vital signs, and get graded live. Okay? So there will be lots of orientation to what to do. There will be practice doing what we taught you to do with standardized patients. And then you'll have a go live, do something, and be assessed doing it. So the strategy this year is a very intentional, present it in class, practice it, and then practice it with feedback, and then do it for a grade. Okay? Somehow we got to help you escape worrying about the grade all the time, because it really begins to be a big barrier when you're trying to do patient care stuff. it's important because you want to pass, and you don't want to do badly. So that, I got that, I mean, I really do. But at a certain point, when you just keep worrying about what you're doing for a grade, you don't get free enough to actually learn. You know, it's just a middle ground. You'll see what I'm talking about when you get into it. But we're trying very hard this year not to make the grade such the issue. I want the learning to be the issue. And you need to, and when you're doing skills, you have to hear about it and you have to practice it where you can mess up. If you don't practice enough, then the test is nerve-wracking. If you practice enough so that you know what you're doing, the test doesn't become such an issue. And that's what we're going to do for each of the modules. Learn diagnostic techniques. How do you examine eyes, for example? There's a lot of tricks. There's a lot of mess. You know, head examination is pretty complicated anyway. How do you do it? Do it, and get feedback before you actually have to go do it for real. The only problem with what we do at this level is you can't get pathology everywhere. So we can tell you how to look at an eyeball. I can tell you how to dilate an eyeball. We can talk about how to look in there and what you're supposed to see. And you can see a lot of normal. And that's good. You want to see a lot of normal, like normal, 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 normal. This doesn't look normal, okay? So you have to see a lot of normal to appreciate abnormal. But it would be nice if we could have enough abnormal here and there that you can see, well, what is it like? You know, they told us in class it did this, but I never have seen that. And there will be things that we're teaching you that you won't see until you go on rotations, no matter what we do. You just can't make sickness of the sort you need across the board. But you'll begin introducing yourself into patient care process on Friday, and then we kind of work it all the way through until the following Friday. And then Monday, a week from this Monday, you'll have your last test here, and then you'll be done with your first class, which will be good, okay? And it'll be a very different kind of test than what you've been having, because it's all been a certain type of thing. We'll ask a lot of questions, and it'll probably be a monster test. They'll have a lot of questions on it. So you'll kind of see how it begins to feel moving forward, okay? Any questions about just the roadmap? Y'all are in good position. Just looking at your class versus other classes, y'all are doing fine. I mean, you may have made grades you haven't made in your life, and that bothers you, and that's true for some of you. Don't worry about it. It gets better. You'll get better. I suspect that each one of you probably thinks you're probably a better student right this second than you were when you walked in the 1st of January, because you had to kind of gun it up. And no matter how much I try to push you to get to the high level, it's hard to get there until you have pressure on you. And I hate that. I mean, I hate that you have to get pressure to kind of get there. It's just part of the experience, okay? Don't run from it, but we don't have to live this way forever either. So it's not going to go forever. But your class is doing fine. Y'all are a very respectful class. You have tried to do what you've been asked to do. And you pay attention. You want to make good grades. And I have not seen anybody who was not interested in trying to do well with what it was they were supposed to do. So that's noticed, and that needs to be told to the class off and on, because there's so much critical that goes on that you may lose sight of tremendous amounts of good. So I feel like we need to talk about doing well, as well as we need to talk about how to improve in different areas. So I've been very pleased with your class overall. I haven't written y'all off. And I don't ever write classes off, but I am interested that you do well. And you all have gotten better. I can just see that across the board. Generally, everybody's gotten better and should be feeling a little bit of confidence in what we're doing. Okay? Any questions about where you are? Okay. Paul's got a smile. Where are you? Where the hell are you? Well, we're going to get to middle status exam sometime in the middle of the summer, you know, orientation to person, place, and time. So we'll get there. Okay. Any questions? Okay. Let me tell you what this little piece is, just in a big overview, and I'm going to ask some questions before I kind of get into it. How many of you have taken a biostatistics course? Okay, so I'm taking, not everybody. How many people have not? And raise your hands high if you have. It's okay if you have not.
I've taken Statistics.
Yes, statistics, but biostatistics is statistics, but in a life science sort of way. How many of you have taken a course on clinical study design?
Like epidemiology.
Epidemiology might have it here, but the courses are usually called, it could be drug study design, clinical study design, okay, a hand, okay. Where'd you do yours at?
OU,
Oh, was it in college, which college was it in?
public health.
Okay, so they will do some stuff there because epidemiology, you have to understand where information comes from, where the data originates, and how seriously you take it, and how to find information. So this little piece on evidence-based medicine, it is a requirement, an accreditation requirement for PA programs, and it really is a requirement for almost anything in health professions. I can't imagine it not. And we'll kind of work our way into it. You will have an opportunity to interact with evidence-based medicine across the year, and it will show up sometimes in your patient care simulations, and then there'll be some other times where we'll talk about medical information and how do you use it. If you read this paper, you're just going, duh. And it's just kind of complicated. If you've had to deal with studies, if you've ever worked with studies and research before, it's a lot of details, and it kind of is its own world, okay, a total world. And the whole of healthcare is underpinned by all of this kinds of information. We have to keep up with it in some way and interact with it, and it will be very hard to do. I'm going to just call out what it's going to be hard to do. But I want you to understand some definitions and aspects of it. And this really is an introduction and a foundation for language that we will be using in other things with evidence-based medicine as the year unfolds. So this is very introductory. Let me ask you another question. How many of you have learned search strategies in the library for research, like Medline research? Okay. How many of you have never had to use medical literature to find something? Because there's one, okay. Nothing deep? You never had to go find anything? Okay. How many of you are comfortable with online searches using Medline searches? Dean, you've ever done one of those? No? Okay. How many have used other databases? Who has used UpToDate? Okay, a few. Okay, seen UpToDate. Has anybody used the Cochrane system? There's like a Cochrane database. Okay. All right. So different ones have had different backgrounds with it. And you know, when our librarian came through here, she introduced you to some things on our computer here at Oklahoma City University, which is pretty good. Okay. What else do I want to ask about this? How many of you have been involved in clinical research? Tell me, I'm just curious, tell me what you did. What you did?
I did biosignature studies for the OU Children's Emergency Room.
Okay, okay. April, what'd you do?
Like nothing like that, just in hygiene school, we did different
Okay,
stuff
okay,
related
but
to
you've
mouth.
had some, you've been through health professional curriculum, so
Yeah.
you had some stuff. Okay,
I worked on hydration in children and their parents.
okay, where did you do that?
University of Arkansas.
Okay, down Little Rock? Or in
No, Fayetteville.
Fayetteville, okay. You did, Jenna? What did you do?
In undergrad, we had to do a lot of studies on undergrad students and muscles, like kinesiology.
Uh-huh, okay.
And then I did a study in cardiac rehab on BMIs and
Mhm.
heart functions.
Okay. So you kind of familiar, so y'all, the ones who've done it are kind of familiar with what people look at and how they gather information. Okay, how many of you feel like you're really, really red hot using statistics to evaluate information? Okay, if anybody, okay, April, you feel pretty good with it?
Yeah, I mean,
Okay.
it's been a while, but I'm good at it.
You've been there before.
Yeah.
So it should come back, okay.
I rock it.
Okay, well, we're not going to do statistics today, but I'm going to introduce some categories and terminology. Okay, I think that's about it, all right? let me just crank through here. Let me try to get y'all out. So we can post those grades.
Yes.
Which is a big, important thing to do. Okay, here is a quick YouTube. This is what we call open class. Okay, fortunately, it's only one. Okay, don't do this to me. 100% that ought to kill us.
Did you say my grade?
Have y'all been having trouble
Because
today?
if you did on actually.
That might be it. Let's try this.
No, you just start with black.
Okay. I don't want that. Hey, let's see. Let me try again.
My nose was. Maybe that's always my nose. This bleeds all the time. Just as I look, it just looked like you had like more on your skin. Well, I noticed it. I was like, oh my god, if I get a bleed out of me, so upset. Oh, it was just randomly. But it's always
The formatting's not great, but I know.
always this side.
Oh, yeah, no, it's perfect.
I think my allergies are just
It's probably I have like headache, like in my neck.
Like where one time and then
me too.
That is not good. Okay.
Is there a button for these?
I don't know. I'm up here on the control panel. I've got my volume on here. I've got my volume on the screen. And I got it on here.
Where does she?
I do not know.
Dad, no, it's not. Like your outer experience.
See what's
I like
Medical terminology. The handout? Yeah, I think so.
Oh my god.
Oh my gosh.
That's why you're really good at like just study like top things. Like literally standing at the coffee table just like
Who?
No, we weren't basically.
Last night, we were going through like the compartments, I like was standing at a coffee table and I was like, I just,
You were standing on.
no, I just like got my foot up on it.
No, that's just.
I haven't ordered it yet. I was gonna wait till this weekend. I was gonna wait till this weekend to ask him for his birthday.
We're jam. They're like the exact same. It's exactly the same thing. All the time. It's so nice. Yes. He got it and like played it and like too much and he was No. It's like it's how I go to sleep. Like I do this right before I fall asleep and it's like the perfect thing for me to like have like numbing brain function, if that makes sense. I love it. Also, I figured out I'm like randomly really good at it after I've had a beer. like so much better. Yeah, like so I'll be like looking at it, I'm like, what is this? And then I'll like go out and I'll chill and I'll come back and like, oh, it's this. And like do the whole thing. I'm like,
That's what, if I don't know it, I usually don't use a hint, I'll just put it down.
yeah.
And I'll
No, I don't
pick
use
up and like,
I don't use a hint unless I've come back like multiple times and still don't know it.
Oh, that's fun.
I don't mind, I mean, I can also,
What are you talking about? Yeah, maybe like later. Chill.
Yeah, it is. Sometimes you just gotta go.
We are
Is there an end?
but see, the thing is, when I was watching it, well, I would be asleep by 9:30, adding them, and I'm trying to like catch up.
Like
I don't mind.
Yeah, it doesn't. Mine's like, I mean, I will different parts of the world. It's like literally, it's like all night. I'm gonna go home. And I've done.
It was just fun. It wasn't critical. It was not critical.
I don't care.
You can, when you go home, you can click it and put it on play, it just runs it down. I had no idea. We got it operating every place it's supposed to operate, so that's another thing. Wow. Man, that's not fun. Okay. Evidence-based medicine, I'll have to do it without that deal, without the program. Okay, what is it? I have a definition from you. This is from British Medical Journal back in the mid-90s. David Sackett is the one credited with giving the definition. Conscientious, explicit, judicious use of current best available evidence in making decisions about the care of individual patients. There's a lot of stuff kind of loaded into that, so let's kind of unload it a little bit. So the best practice of EBM calls for integration of three things. There's three pieces to evidence-based medicine. And it's amazing to me that it actually only has originated since the 90s. It's not an old thing at all. There's individual clinical expertise. That is what you've learned by taking care of patients over time. And a lot of clinicians spend a lot of time with that. They value that very highly. My experience is. Okay, now that's kind of a deadly attitude to ultimately fall into, because your experience is your experience. There's nothing wrong with it, but what if you have not seen comparable things? What if your experience is more limited with an area? So you do have to have the individual clinical experience. And it's important, but you have to combine that with the best available evidence, which means you have to find some way to keep up with information over time, and we'll look at what's good evidence. And then finally, a big and, a patient's values and expectations. Sometimes there might be three ways to treat something, and there may be the way that you like to treat it that you have found to be very effective over time. But those three ways will have pros and cons. There will be conveniences and inconveniences. There will be expenses. There will be other things embedded in that treatment. And it's very important to ask the patient what thing they might want to choose. Provided they're all equal, then there ought to be some choosing in there. Sometimes they're not all equal, but they're not that far apart. But the negative aspects might be so heavy that a person would rather take a little less effectiveness as opposed to having a big, huge problem. So and those things vary between patients. Some people are more prone to certain problems than others. So you have to involve not only what you think works well based on your experience with what the literature says is acceptable, reasonable, and good, you also have to ask the patient what they want. And that's the one thing that we'll talk about some more at the end of the week on patient-centered care is rather than telling somebody, it's interact with somebody. You don't want to go to a healthcare provider and just have them sit up there, you need to do this, you need to do that. Well, thank you. I mean, and you see that a lot. You need to have somebody who is confident and competent and can be authoritative when the patient asks for it. But you interact with a lot of patients who are quite well aware of what's going on, and they'll have a view. And it's important to ask those questions. And that all together lets you make a decision. So evidence-based medicine leans that way. Here's the three little diagram that shows that. Individual clinical experience, best external evidence, patient values and expectations, and the sweet spot is where all three of those things come together. Why do we even have it? You know, if you're like me, when I first heard about this stuff, I thought, well, this just seems kind of logical. Why is this not the way it's always been done? Well, mostly it hasn't always been done this way through the eons at all. Scientific medicine really didn't pop up until the 1900s. I mean, when you finally had science as the basis for things to a large extent. Will Rogers has a good saying here. It isn't what we don't know that gives us trouble. It's what we know that ain't so. Practitioners will, let's say they use drug A over and it works, it works, it works. It might not be the right drug to use. There may be complications with it. And they don't ever see the complications because those people show up in ER someplace else. So they keep having this impression, I'm doing the right thing, I'm doing the right thing, I'm doing the right thing. But they may not see the end points of all the stuff going on. Or maybe it just doesn't work like they say it works. There's a lot of drugs that are now falling off into the wayside, surgical procedures that are never done because they were done for a long time. We always thought it was important and good to do it that way, but it turns out they really weren't that effective at all. So that's knowing what things that really aren't so. They really don't do what we say. Here's some examples of people who thought they knew what was what and it caused problems. I know that most of you probably have at some point interacted with people who were exposed to thalidomide as a fetus. Okay, this goes back into the 40s and 50s. It was a medicine that came out for nausea, and it was used for nausea in pregnant women. So it's like, you know, that's a fairly common adverse event for people who are pregnant, is to be nauseated, and they gave them thalidomide to be helpless, also to help them sleep, help them not be nauseated, help them relax. Well, it turned out that that medication caused a number of birth defects because it involves itself in organogenesis. And specifically, one of the big adverse events was phocomelia. And phocomelia is just ill-developed limbs. So you might have an arm that is only this long and the hand is here. It's not a fully developed arm, or leg. When I was growing up in high school, there was a girl in our class, and well, not actually, she was one class behind mine, and she was a phocomelic individual. And she was probably this tall, and her legs were probably that long. It almost looked like E.T. I mean, she almost looked like E.T. I didn't have that word to describe her at that time because we didn't know. She also had a prosthetic arm, you know, prosthetic hand. And she was a highly independent, very smart person, and she was very successful in life when it's all, you know, been said and done. But her mother was married to, her mother was married to a man, and he was in the Air Force, and they were stationed in Germany in World War II. And she had, or right after, they were occupation army after World War II, they were positioned in Germany. And she took this when she was pregnant, and that's why this child came out with phocomelia. She ended up with birth defects that were pretty significant. So for a long time, everybody thought that was a very good drug to use, and America never did approve. Thalidomide was not approved in America for use, but there were a lot of Americans who've been affected by it because they were in countries that had the drug available at that time. And there was a push to bring thalidomide into America for use. But there was, they give you the example here of this one physician pharmacologist didn't want to happen because he felt like it wasn't well appreciated what the adverse effects were. As time went by, it began to be obvious that a common link to birth defects was the fact that thalidomide had been used during, you know, first trimester. So it's a problem. So it didn't make it here. I remember this study really well, the cardiac arrhythmia suppression trial called CAST. There was a time back in the late 70s, early 80s, where after people had a heart attack, they're always monitoring with EKGs. They would see a lot of PVCs, premature ventricular contractions, and there was this whole science about it. They felt like if you had PVCs after an MI, that you were at risk for a fatal malignant arrhythmia, and they had to make them go away. So everybody post-MI was being monitored. If they had couplets, bigeminy, 2 PVCs in a row, or trigeminy, 3 PVCs in a row, they had elaborate classifications for how many PVCs you would have. They would treat them with antiarrhythmic drugs to make the PVCs go away so they didn't see it. And they felt like they were prolonging people's lives by doing that they wouldn't go off into the fatal VTAC, or VFib, and just drop dead suddenly at home from just sudden fatal arrhythmia. It turned out that the medications that were used actually caused more death than not using them. And this was, it really particularly strikes me because I remember at the Health Science Center in San Antonio, they were one of the big research sites for the antiarrhythmic drugs, and they would monitor everybody like all get out. And the medications that were used were very hard to use, and they were monitored by drug levels, and you had to fine-tune that. And part of what we were supposed to do was to help that fine-tuning, and we did a lot of that. But there was never the evidence that life was, made better and that risk was reduced. And when this big trial came out in the late 80s, it just revolutionized the way people dealt with it, because overnight people were pulling folks off of drugs right and left because they felt like they were leaving but high risk to do that. So that's another case where everybody thought they were doing something right, but they actually in the end ended up causing quite a bit of harm. And there's no telling how many people died. There were big lawsuits popping up like anything today. If you find out that there's harm from a medicine, please call 1-800 so-and-so firm, because the lawyers are trying to make business for themselves, but they're taking advantage of systems that bring risk to a patient willfully without good information. So this is a big one. So these two are ones just to have in the back of your memory if you need a reason why it's important to actually know what you think you know and prove it before you start subjecting a large number of people to it. Here's some of the history. I don't expect you to remember everything. There's a few things you'll need to remember. In the 1960s, medical decision making began to be questioned. Before the 60s, pretty much what the physician said was it. If they had a belief about something, then that was kind of the gospel. Well, Dr. So-and-so, they're an eminent group and they have all said this, and so people just kind of fell over and did it. And it wasn't based on nothing, but it may not have been based on enough, to make it legitimate. So it started to get questioned. Everything fell apart in the 60s. That's where everything that had been done was questioned. All the way from social things to medical things, what had been done was not necessarily just accepted as the gospel truth, about anything. So that was consistent with the era. In '67, a doctor named Dr. Feinstein identified biases in medical decision making, that people were biased towards doing one thing or another based on what the word was on the street, not what the evidence was that would support it. In 1972, Effectiveness and Efficiency by Archie Cochran, this is the Cochran of the Cochran system and database, identified lack of evidence from controlled trials to support medical decision making. They begin to say, you're using quinine for leg cramps and it doesn't do anything. There's a lot of stuff out there right now that doesn't do anything that everybody thinks is important. And Oklahoma is full of almost a mysticism about this medicine and that one, and this remedy, this home remedy is very useful. And there's just no evidence to back them up. In the 80s, many studies were published identifying flaws in medical decision making for individuals and populations. So it just kind of kept working its way into the psyche until finally, in the 1980s, David Eddy, an American physician and educator, first used the phrase evidence-based. We hear it a lot now, but it really wasn't a phrase that was used a lot. And he is the person who is credited with launching the current guideline craze. Nowadays, everything has a clinical guideline. Heart Association has guidelines for blood pressure, guidelines for cholesterol. There's the American Diabetes Association, clinical guidelines for diabetes management, guidelines for everything in the urology world, guidelines for infectious disease, so they're everywhere. There were no guidelines before then. It's just isolated articles floating around, and what did Dr. So-and-so and his group think, and everybody just kind of did that. And now there are guidelines. Thank goodness there are guidelines. I think they're very helpful because there's no way to read everything about everything and keep up. You need some place that says this is the best evidence for what we do and why we should do it that way. So the term evidence-based medicine was introduced in medical education in the early 1990s. So you see it's not that old at all, and had roots in clinical epidemiology. A name that's interesting, Gordon Guyette, there's a program at McMaster, and he talked about evidence-based. A lot of people went to Canada to learn how to do evidence-based medicine. Dr. Vanetta went up there. He did like I don't know if it was a summer sabbatical or a 6-month sabbatical, where he went up to McMaster University, and all kinds of medical educators were trying to learn the evidence-based medicine approach, because it was perceived to be a better way to do things, and it was a counter to all of the kind of mystical approach to making decisions about taking care of people. So that location is interesting for that reason. Then David Sackett in 1996 made that definition of evidence-based medicine that I gave you at the very beginning. So it kind of brings it all together. So we are not really 20 plus years away from it, not that far. So it's still there, and will still continue to evolve. This slide is a good one because it kind of summarizes several things about evidence-based medicine. Opinion-based medicine is what they called it earlier, relies on memory, and it emphasizes experience. What have you seen work, Dr. Jones? Okay? That was before the 60s when it fell apart. Then it became physician-centered evidence-based medicine. That's about 1992. That was based on published science. Practitioner experience is very important, and it acknowledges patient values, but that's not a basis for decision making. It's still what I think it is. I hear what you're saying, but here's the best thing for you. I know the best thing for you. And then finally, you move to patient-centered evidence-based medicine, where it's all those things: clinical evidence, focus on patient understanding, but you integrate your experience with what the patient wants. And those are important. It is true, and you'll find this, you don't have to do everything you want to do to a patient. They may not want everything you have to offer. It's very important to find out what they want and what they can deal with at any given time. And that might fly in the face. If you're a controlling sort and you like to be in control, this is the best thing, and kind of paternalistic, you might get a lot of pushback today from a lot of people who they'll listen to, but they'll go off and do what they want to do. Then they'll come back and you'll be mad at them because they didn't do what you told them to do. Well, did you ask them what they wanted? Okay, it's your body, it's your life. If somebody wants to be sick and smoke cigarettes and not take care of their diet and not exercise, it's their right. They can do that. It's their life. Now, if they start fussing, I always tell patients this: you can do what you want to do or not do anything at all. That's your choice in your life. But if you come back and start complaining to me about your choices, I don't want to hear that. Okay, you can have your life. I'm with you. I'm not going to fuss at you or carry on. I will give you my best advice. And then you can choose. If you choose not to do something and then you start complaining about what it was that I talked to you about, that's on you. It will be on you. But then at that point, if you really want to help, we'll go in another direction. Okay, so I think you guys have to understand, you choose, but it's your choice. Okay, other factors that get in the way of evidence-based medicine. In spite of the need for evidence in medical practice, we often fail to get it. Clinical performance and up-to-date knowledge can deteriorate with time. When you graduate from this program, you will be as red hot as you are going to be at a certain level with some of this information. And then if you go into a certain type of practice, you'll become more red hot in that, and everything else will cool off. And if you don't go back and work with those other knowledge bases, you won't really know it. So that's just normal. Okay, I know it doesn't feel good, but it's just kind of normal. You'll be good at what you need to be good at. Other things will start to dim. Just don't forget that your knowledge base is dimming over here so that you fail to ask for help when things come up in that category. That's where I see problems. It's not that we don't know that we're losing ground. It's just that all-encompassing sense of I know best in this area where I'm on my strong ground, then it kind of extends into all kinds of other areas. That's kind of a deadly thinking over time. Time and demands take away from time to read and keep up to date, and how. I will just have to emphasize that, and how. It's a huge problem. Okay, how can you practice evidence-based medicine? This, I'm just going to run through a series of slides that give you a technique. Have any of y'all heard of the PICO method? P-I-C-O. It's just an approach. It's not the only approach. It's not the be-all, end-all. It actually just kind of helps you organize a way of thinking. So I'm using it mostly because it organizes a way of thinking. It helps you become more disciplined in how you approach a patient problem. I don't care if you don't do PICO per se, but I do want you to pay attention to what it's saying logically about how we frame questions and find answers for patient care. Okay, so to do evidence-based medicine practice, you have to turn patient care information needs into answerable questions. You want to locate the best evidence, appraise it for its usefulness, apply the findings to practice, and then periodically review and evaluate your clinical performance. Well, the state of Oklahoma forces you to update your knowledge because you have to have CE to keep a license. Okay, that's going to happen anyway. But beyond the requirement, you may need to keep reading in your own areas just to be on top of it in some way. So let's look at this. The PICO method it's useful to form answerable clinical questions. PICO, patient, intervention, comparison, and outcome. The patient or problem, the intervention, what are you going to do, the comparison, and then the outcome. Okay, patient, a part of this, not too hard to understand this. You got to identify the patient or a problem. He could also be problem, could be the problem or patient, and or the population. So you want to describe either the chief complaint or the general patient's condition to a larger population. When identifying the P and PICO, several things that are helpful to ask. How could you describe a group with a similar problem? How would you describe the patient to a colleague? What are the important characteristics of the patient? Could be, you know, I'm interested in, let's just do the lutamide thing. Pregnant women, first trimester, nausea. Is it better with or without this drug, you know, with the drug versus without? Is there less nausea? So it's just kind of breaking it down to who are you looking at and what are the important features. Information you might consider when selecting patient characteristics. You might do patient's primary problem, main concern or chief complaint, disease or health status, and then all kinds of other factors, age, race, sex, previous ailments, and current medications. There's a lot of things that might define the population that you are working with that are pertinent to the question. Now the second part is intervention. That's the second step. It is important to identify what you plan to do for your specific patient. The interventions can be a lot of things. It can be nothing. It can be a drug. It can be a diagnostic test. It can be a non-drug treatment or a surgery, adjunctive therapy. So a lot of things can be done for people, all the way from nothing to very specific things. The comparison is the main alternative you are considering for your patient. Should be specific, should be limited to one alternative choice. It's very difficult to ask a clinical question where you're comparing one thing to like 5 other things. It's a harder logic to do. It might be the question to ask, but you may not be able to find the evidence that answers that type of a question. So you do better to break it down to a comparison with one other thing. And it's very important to get your comparison down to a very tight group if you're doing medical searches online. The more you can frame it in very specific, discrete terms, the easier it is to find information. And then your outcome specifies what you hope to accomplish, improve, or affect or change. The outcome should be measurable. You always have to measure. And the outcomes can be relieving or eliminating a symptom, improving or maintaining a function, or enhancing aesthetics, for example, cosmetic surgery. Specific outcomes enhance the search process and allow for better yield studies. So the thing about doing outcomes, you have to define it as tightly as you can. It needs to be as measurable as it can be so you can actually take readings and have numerical information to compare. Here's an example, just an easy example. Start the patient or problem. Starting with your patient, ask, how would I describe a group of patients similar to mine? Balance precision with brevity. Here it is. In patients with heart failure from dilated cardiomyopathy who are in sinus rhythm. That's pretty specific, okay? Patient with heart failure from dilated cardiomyopathy who are in sinus rhythm. That is a unique population right there. The intervention. Ask which main intervention am I considering? Be specific. Here it goes. Would adding anticoagulation with warfarin to standard heart therapy failure, so the intervention in that heart failure group from dilated cardiomyopathy who are in normal sinus rhythm, do you put anticoagulation with warfarin, would adding it to standard failure when compared with standard therapy alone, so the group is you're either going to use anticoagulant with standard therapy or not use anticoagulant with standard therapy, and then the outcome, would it lead to lower mortality or morbidity from thromboembolism? Is this enough to be worth the increased risk of bleeding? Okay, and y'all get to that. It's kind of a question that kind of floats out there. Heart failure is very common from a lot of different reasons, and one of the big issues in heart failure people is development of clots and throwing them to get a stroke or a heart attack, and that can be the end. So you'll get to this when you get to cardiology, but that's an example of the PICO process, very specific. This clip, I wasn't going to play today anyway, seriously. I'm just going to leave if you want to look at it to see more examples, you can do that. It may be helpful, may not be, but it's just there. Okay. Now, what types of PICO questions can you ask? In addition to identifying the PICO components, you have to clarify the type of question you're asking because it helps you in looking for information. The types of questions are intervention, which is kind of easy to understand, therapy or prevention, intervention, or it could be a diagnosis. Do you do test A or test B, which is a better test to diagnose X? Etiology or risk, or prognosis. Here's just some examples. PICO for intervention question. 28-year-old male presents with recurrent furunculosis, skin boils, for past 8 months. These episodes have been treated with drainage and several courses of antibiotics, but they keep recurring. He asked if recurrence can be prevented. To convert this to an answerable question, use the PICO method as follows. The question is, in patients with recurrent furunculosis, do prophylactic antibiotics compared to no treatment reduce their recurrence rate? So your P, patients with recurrent furunculosis, intervention, prophylactic antibiotics, the comparison, no treatment, and the outcome, reduction in recurrence rate of furunculosis. Here's one for looking at risk or etiology. George wants to discuss the possibility of a vasectomy. He says he has heard something about vasectomy causing an increase in testicular cancer later in life. You know that the risk of this is low, but want to give him a more precise answer. So your question, in men, does having a vasectomy compared to not having one increase the risk of getting testicular cancer in the future? It's pretty obvious. The population is adult males, the intervention is vasectomy, the comparison is no vasectomy, and the outcome is testicular cancer. Here's one for prognosis. Julie is pregnant for the second time. She had her first baby when she was 33 and had amniocentesis to find out the baby had Down syndrome. The test was negative, but it was not a good experience as she did not get the result until she was 18 weeks pregnant. She is now 35, 1 month pregnant, and asked if she can have a test that would give her an earlier result. The local hospital offers serum biochemistry plus nuchal translucency ultrasound as a first trimester test for Down syndrome. you wonder if this is as reliable as conventional amniocentesis. Do y'all know what, has anybody ever heard of nuchal translucency ultrasound? What it is, it's ultrasound, okay, so you got the ultrasound device, and transnuchal on the neck